Good afternoon. We are back from break and we will move to the next item on the agenda, Agenda 9.2. Item 9.2, discussion and possible action.
Great.
Tricia?
I know Shannon will be presenting. I did just want to mention that although it has been corrected on this screen in our paper books, the title for this item is confusing because it's actually 9.5. So that's just kind of for the record. And thank you, Shannon. I'm going to go ahead and turn this discussion over to you.
Hi, so agenda item 9.2, this is discussion and possible action for a name change of the Enforcement Intervention Committee, currently EIC. We would like to incorporate all units reporting to this committee. So a name change is being requested. The name is being requested to change from the Enforcement Intervention Committee, EIC, to Enforcement Investigation and Intervention Committee, EIIC. So I would like to ask for the board to motion to approve this.
I'll make a motion to approve the name change to Enforcement Investigation and
Enforcement
Intervention Committee. Thank you.
Yeah.
Great. We have a motion on the floor in a second. Any comments or questions from board members? All right, we will open up for public comment. BRN moderator, please take us to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments in the WebEx. There are no public requests for comments there in your location in Sacramento. Would you like me to close this window?
You can close the window. Thank you. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Patricia Nguyen. David Lawler.
David Lawler, yes.
Vicki Granowitz.
Granowitz, yes.
Allison Cormack.
Cormac, yes.
Neelu Patel.
Patel, yes.
All right, motion carries. Oh, did I leave? I'm sorry, Jovita. Jovita Dominguez.
No worries. Jovita, yes.
Thank you. Now it carries. Moving on to item 9.3. This is information only. Presentation on the intervention program, including but not limited to statistics, program updates, the intervention evaluation committees, roles and responsibilities.
Once again, Shannon Johnson will be presenting this item.
Hi,
Thank you,
so
Tricia.
I do have a PowerPoint. Let me get that shared with all of you right now. I just want to make sure that you can see that. Okay, great. So 9.3, this is an intervention program presentation. We'll go ahead and start with, let me move something out of my way real quick. We'll go ahead and start with the committee's composition, which is dictated by Business and Professions Code Section 2770.2. And I just want to make a quick note at the bottom of each slide, bottom left, there is a reference point to either Business and Professions Code or regulation and where you can find this language. So the committee's composition is dictated by 2770.2 of BPC. Each committee consists of five members on a committee, 3 RNs, 1 physician member, and 1 public member. The RNs need to have demonstrated expertise in the field of chemical dependency or psychiatric nursing. The physicians must hold an active license specializing in the diagnosis and treatment of addictive diseases or mental illness. And the public member needs to have knowledge in the field of chemical dependency or mental illness. IEC members are only permitted, like the board, to serve 2 consecutive 4-year terms, and that is pursuant to BPC 131. There may be a 1-year grace period once the term expires. These appointments or reappointments to the second term are all by vote of the full 9-member board. The IEC's expected time commitment. So when an individual accepts the appointment to an intervention evaluation committee, they're making the commitment to ensure they review cases thoroughly prior to each meeting, be prepared with any questions for case clarity, and then attend all the scheduled meetings. And typically IECs meet 4 times a year. And by the way, there's currently 9 IECs in the state. The committee members have the responsibility to evaluate the nurses that request participation into the program according to the guidelines prescribed by the board. They're also required to review and designate treatment services needed for recovery, included but not limited to inpatient treatment, intensive outpatient treatment for rehabilitation. They need to consider, in the case of each nurse, whether or not the nurse can resume the practice of nursing. They need to call meetings as necessary to consider reports of the RNs. They need to make recommendations to the board's program manager regarding the terms and conditions of the intervention agreement for each registered nurse participating in the program. And this includes, but it's not limited to, treatment, supervision, and monitoring requirements. The board's program manager may then approve or deny the recommendation made by the committee. The committee has the responsibility of calling meetings as necessary to consider the request of nurses who want to participate in the program and to consider reports of RNs participating in the program. The members will receive the recovery progress and discuss whether or not the committee feels there needs to be any changes recommended to the board on the recovery plan. The members make the most informed recommendation for the recovery plan, and it's based on all information pertinent to the participant's case. The recommendation may or may not include requests from the participant, as well as any other changes to the recovery plan that the IEC feels may be necessary. The IEC's role is to ensure the appropriate recovery plan is in place for the RN at all stages throughout their participation in the program. The committee does have the authority to accept a participant into the program or terminate them from the program without making any recommendation to the board's program manager. However, the board's program manager is the only authority that can deem a terminated participant as a public safety risk. Maximus is our contracted provider for the board's intervention program. Maximus has a program director, an operations manager, clinical case manager, and compliance specialist. So the program director at Maximus, it's an RN with experience in substance use disorder and psychiatry, and they're responsible for the overall program operations and the clinical activities. The operations manager is responsible for the oversight of the program operations, and then the clinical case manager, they're licensed RNs who are trained and experienced in working in psychiatric and substance abuse settings. And they're the ones that are probably on the forefront with each of our participants. The board staff, our program manager, which I announced earlier, that is designated to Jaspreet Pabla, one of our deputy chiefs at the board. So each IEC under BPC 2770.8, they operate under the direction of the program manager, and the program manager has the primary responsibility of reviewing and evaluating all of the recommendations from the intervention committee. The program manager is also responsible for determining whether or not An RN who's denied admission into the program or terminated from the program is a threat to the public or to their own health and safety. This next slide, there's a lot of information here, but this is the uniform standards. So the board must adhere to uniform standards, and they were put into law back in 2008. There was an amendment to the uniform standards number 4, and that was in March of 2019. And I'm just going to go through kind of a high level overview of these, but you can find a version with a lot more detail. But each of these standards is what we try to adhere to at the board. So number 1, it requires the applicant to undergo a clinical diagnostic, and this is pre-IEC. And so that means that it must be conducted by a licensed practitioner who hold a valid unrestricted license with 3 years experience in substance abuse disorders, and it needs to be approved by the board. The report that they provide must state whether the licensee has a substance abuse problem, whether they're a threat to themselves or others, and then recommend treatment, practice restrictions, or other recommendations related to the rehabilitation and safe practice. Uniform standard number 2, there are practice restrictions that apply to each licensee who undergoes a clinical diagnostic evaluation, which are ceasing practice during the clinical diagnostic evaluation timeframe. And then while awaiting the results, they have to be drug tested at least 2 times per week based on uniform standard number 2. This standard is only related to the initial diagnostic evaluation, and it does not pertain to uniform standard 11, which I'll touch on towards the end. After review of the results, the program manager must determine whether or not the licensee is safe to return to either part-time or full-time practice. However, no licensee can be returned to practice until they have at least 30 days of negative drug tests. Uniform standard number 3 states that the licensee must provide to the board the names, addresses, phone numbers of all their employers and supervisors, and they must give specific written authorization to discuss all aspects of employment. Uniform standard number 4, the board and the vendor is required to adhere to all aspects of testing requirements, and that includes the frequency, randomicity, the method of notice to the participant, number of hours between the notice and test, the standards for the specimen collectors, observed testing requirements, any backup testing, for instance, if they go on vacation, and then the time frame from the test to the result. There are 2 levels of random drug testing. Level 1 is 52 to 104 tests per year. Level 2 is at 36 to 104 tests per year. Level 1 is the range for a participant in the first year of their program, and level 2 is for the subsequent years. However, nothing precludes the board for increasing or decreasing the number of tests for any reason, and there is also a list of exceptions to this testing listed within the standard for possible decreasing the test in level 1 or 2. In uniform standard number 5, the board may require the participant to attend nurse support group meetings. At those meetings, the nurse support group facilitator must have a minimum of 3 years experience in the treatment and rehabilitation of substance abuse and must be licensed or certified by the state or other nationally certified organizations. The facilitator must not have a financial, personal, or business relationship with the participant, and the facilitator must provide signed reports for meeting attendance, including their participation level and their progress. They also need to report any unexcused absences within 24 hours. Uniform standard number 6. So the board must consider criteria for treatment, which includes the recommendation of the clinical diagnostic evaluation, their license type, their licensee history, their length of sobriety, their pattern of substance abuse disorder, their treatment history, medical history, any current medical conditions, nature and duration and severity of their substance use disorder, and whether or not they are a threat to themselves or the public. Uniform standard number 7, the board may require the use of worksite monitors, which must not have a financial, personal, or familial relationship with the licensee. The worksite monitor, their license scope of practice must include the same scope of practice the nurse is being monitored for. They must have an unrestricted license within the last 5 years. They must sign affirmation that they've reviewed the participant's contract and agree to monitor the licensee. The monitor must also adhere to a face-to-face contact at least once per week, interview other staff in the office regarding the licensee's behavior, and review all of their work attendance. The worksite monitor must report substance abuse within 1 business day and provide a written report within 48 hours of the occurrence. And they also must complete and submit monthly reports or as requested by the board. The licensee has to or must complete the consent forms and sign an agreement with the worksite monitor and the board to allow the board to communicate with the worksite monitor. Uniform standard number 8, when a licensee tests positive for a banned substance, the board must issue a cease practice. They must contact the licensee to leave work. They must notify the employer and the worksite monitor that the licensee may not work. The board will then need to determine if the positive test is evidence of prohibited use by consulting the specimen collector in the laboratory. They communicate with the licensee or physician who's treating the licensee and communicate with any treatment provider, including possibly the nurse support group facilitator. Uniform standard states that when the board confirms that a positive drug test is evidence of prohibited use, this standard particularly requires the board to follow the procedure in Uniform Standard 10. And 10 states that major violations include, but aren't limited to, failure to complete the ordered program, failure to undergo clinical diagnostic evaluations, multiple minor violations, treating patients while under the influence, any related act that would constitute a violation of the Nurse Practice Act or state federal laws, failure to drug test, positive random drug testing, and then using, making, or altering any object to defraud their random drug test. The consequences for these major violations could include, but it's not limited to, ceasing practice, undergoing a new clinical diagnostic evaluation, and then they must test negative for at least a month of continuous random drug testing before being allowed to go back to work. It could possibly lead to termination of their contract or referral for disciplinary action. There are also minor violations that include, they're not limited to, but they include untimely receipt of documents, unexcused absences for of group meetings, failure to contact the board or vendor when required, and then any other violation that do not present an immediate threat to the violator or to the public. And then there are also consequences for these minor violations that include removal from work, possible practice limitations, required supervision, increased documentation. They may get a warning notice. They'll be required possibly for re-evaluation or testing, drug testing, and then other actions as determined by the board. Uniform Standard 11, the licensee must meet the following criteria before submitting a request to return to full-time practice. So they must demonstrate sustained compliance. They must demonstrate the ability to practice safely as evidenced by current worksite reports, evaluations, and any other information relating to the licensee substance abuse. They must have negative drug screening reports for at least 6 months. They must have 2 positive worksite monitor reports and complete compliance with all their other terms and conditions of the program. Standard 12, the licensee has to meet certain criteria to request a full and unrestricted license. So they must demonstrate successful completion of the recovery program. They must demonstrate a consistent and sustained participation in activities that promote and support their recovery. That includes ongoing support meetings, therapy, counseling, relapse prevention plan, and community activities. They must demonstrate that they're able to practice safely, and they must have continuous sobriety for 3 to 5 years. Uniform Standard 13, this standard explains all the requirements of any vendor that is obtained by the board for intervention services, including, this includes our testing collectors, our group meeting facilitators, our worksite monitors, and treatment providers. And then there are 3 more standards, 14, 15, 16, and let's just go into more detail of those vendor requirements. So that can all be found and in more detail in the uniform standards, which is in regulation. I want to share a few comparisons between the intervention program and probation. One of the biggest differences, it's not listed on this slide or the next 2 slides, it's that the conditions of probation are based on disciplinary guidelines, and that's set forth in regulation. So once there's a final order, which this board is, used to seeing those disciplinary orders, the conditions of probation that are listed in that disciplinary order must be adhered to. And that's what guides us for probation is the disciplinary guideline conditions. Versus intervention, our regulations are defined in 1446 through 1449 of California Code of Regulations, and then it's further defined in the uniform standards. Also, during intervention, terms of recovery, the recovery agreement are fluid, and they're updated as the recovery needs change. As probation, those conditions remain the same unless there's an additional action taken against the licensee or the license, and then a new decision and order is then adopted and made effective by the board. Intervention also has work supervision levels, as I mentioned earlier. So with intervention and employment, it's that they meet with their worksite monitor at least once per week. Probation, we may apply a supervision level, which is listed in the conditions of probation. The levels are maximum, which it's one-on-one at all times. So that worksite monitor needs to be in that work area with that probationary nurse at all times. We have moderate, which that work support or worksite monitor has to be with them at least half of the shift. And then minimum, it's contact at least once per day. So that's a little different from intervention as well. I'm not going to go through each of these specifically, but as you can see, or maybe I will. So there's an assessment. So they're very similar otherwise. The assessments and orientations are conducted in probation. We conduct an orientation and we go over all the conditions of probation. And there is an intake conducted for intervention with Maximus with the case manager. We also have clinical assessments. So with our probationers, they have to go through both a mental health evaluation as well as a physical evaluation. And then intervention, they have the clinical diagnostic evaluation. They both have to attend treatment if that is what is recommended out of their assessments that are done, whether it be residential, partial hospitalization, intensive outpatient aftercare. So that's determined through that as well. They both have to do drug testing. It's the same drug testing facility, same collection sites. They both have to attend nurse support group. They both have to attend 12-step. They both, the intervention, or excuse me, has a fee that they pay monthly. And just to note, we are one, I believe, I think we're the only board out of the boards that have contracted with Maximus for an alternative program that we pay the majority of all the fees for our nurses in the program. They pay a $25 fee per month, and we pay all other fees. The other big thing is intervention is completely confidential, probation is not. Therefore, when a nurse completes successfully our intervention program, if there was a complaint filed against that nurse, that complaint completely goes away. It gets purged after successful completion. So there's no public awareness if a nurse completes successfully. And that is why a lot of these items are in place to ensure that, and nothing is 100%, but to ensure that the board feels comfortable with a nurse being successfully completed from the program. The IEC is comfortable with that nurse being successfully completed from the program, knowing that the minute they successfully complete, they have a completely unencumbered license with no public awareness of any previous substance abuse disorder or mental health impairment. So that's kind of the rationale behind some of the reason why they implemented uniform standards years ago. And let me see. And then just public record for probation. If you're not aware, any disciplinary action by the board that remains on the record indefinitely. It will never leave the record. It stays on the board's website as well as nurses' website, including the documentation. However, for the board's website, we do have a retention policy, an internal retention policy, and those documents will be removed depending on what the disciplinary action is at certain timeframes. However, it will always say previous discipline. And through the Public Records Act, any member of the public will be allowed to request that document, and the board is obligated to provide those documents through the PRA, the Public Records Act. So those are a few differences, and that is the end of my slide. So I'll open it up in case the board has any questions.
Board Member David Lawler.
Hi, Shannon. I have two questions. The first is, if a nurse is ordered probation, do they have the right to select intervention instead so that their issue remains confidential?
Yes, so every complaint that we get in to the board, which we get probably, I'm going to say approximately about 800 complaints a month. Every complaint, we do an outreach now. We used to only reach out to those who maybe had a substance abuse linked to their complaint. Now we're sending it out to everyone. So we're hitting about 800 outreach pieces per month. Basically educating them on the fact that we do have a program. What the program is, it's a voluntary program, and they can accept that program. We do have, and the way that the language reads now, even if we filed an accusation against that RN, if we do not have a final decision and order yet, they're still open, or they are allowed to go ahead and reach out to the program and enter if they'd like. And then what we do is, once they're accepted by the Intervention Evaluation Committee, we will withdraw that accusation. So up until the very end, they still have that opportunity to go into the intervention program.
This is Reza. To be clear, though, I think you asked about once they're on probation, at which point I think they are, I mean, that was all helpful information, and probably also.
No, I
Well,
was just curious, is because when we read the orders that says so ordered, 3 years
So
probation.
Once they
can
have
I
a
say-
disciplinary action, there's criteria that they have to meet in order to be eligible for the program. And one of them is they cannot have a previous discipline against their license based on substance use or mental illness. So
Okay.
depending on what the previous issue was, they may still be able to be eligible for the program. But if they do have a disciplinary action, which probation would be one of those actions, it would make them ineligible.
Okay. Thank you.
You're welcome.
Okay, Board Member Vicky Granowitz and then Board Member Neela Patel.
I have a couple of things. First off, in regard to the public comment, there have been some highly charged comments on behalf of the public. And I would, as somebody who sat on lots of boards and commissions and have been called lots of names, I would prefer that the public commenters confine their comments to policy and process and not make character judgments. I have found staff to be ethical, hardworking, and limited often by what we don't see. And so I am just requesting that some of the comments that have been repeatedly made be refrained from going forward. So that's just my personal request. And then I understand this issue is highly charged, that individuals' livelihoods are at stake, and so there is a lot of emotionality around it. I have found a disconnect in a couple of different ways. So it seems like there's a couple of issues. And correct me if I'm wrong, I'm not a nurse, I'm a member of the public, so, but some of the public commenters have alluded to the fact that there has been a change in what they thought they were getting into, participants were getting into, and that it changed as they thought they would be completing their requirements and exiting the program. And I'm not sure if that actually is accurate or if there was some kind of problem with the operator, but somewhere there's some kind of disconnect that I find confusing, and I would like some clarity on that. But even assuming that issue gets resolved, the other issue for me is that it appears that some of the participants, or all these participants, had issues with narcotics, and that's why they are in this program. And now they're saying, or their representatives are saying, that they've completed the program, they're not going to work in areas that involve narcotics, and so they should be able to have their full nursing requirements back because they're no longer going to work in fields with narcotics. But I don't see how you can make that work, because nurses, we don't have a category of nurse that is exclusively for nursing that doesn't involve narcotics. And it's like, would we need to create a whole new program to track these particular individuals? And is their representative saying that's what we should be doing, is creating something so that they can continue to practice? And even assuming that you could create a whole new program, I don't know how you would track that going forward to make sure that in 10 years, they're still not working in areas that involve narcotics. I'm finding this whole conversation to be, it feels a little like DreamWorks to me, like in an ideal world, this is what they would like to see. And so if someone could bring some order to the chaos I feel like I'm experiencing on this issue right now, I'd appreciate that.
I'll try to give a little explanation and then I'm sure Reza and Shannon will jump in as well. So first off, our intervention program is not just for people that have been diverting narcotics or using narcotics. So intervention is for substance use disorder. It could be alcoholism. It could be something that's not related to passing medications or a narcotic issue. Additionally, it also does mental health and mental illness. And so there may be people involved in the intervention program that would not have anything to do with those aspects. But there also may be a person that is a dual diagnosis that has both aspects, the mental illness and substance use disorder. And so just some clarification on that. These people that are entering the program, their trajectory is based on an individual evaluation and can change throughout the process. It is not a one size fits all. And so there may be differences from one person's pathway to another person's pathway. And then to answer kind of a licensing question, we have one RN license. That RN license, which is what we have the authority over here to surrender or to put some discipline on it, is a general license. It is not specialty based and it's not employment based. And so you are licensed to practice as a nurse in any ability that you're hired in to do. And there's no way that we can put a restriction on that. An example would be that maybe someone is convicted of child endangerment. We cannot put on our license that you can have an RN license, you just can't work in pediatrics. We don't have any ability to do that. So outside of the intervention program, we don't even have an ability to say you can do this, but you can't do this. And so the way that we license them with a general RN that allows them to go to any practice area in any kind of employment setting that utilizes an RN license. Reza.
Thank you. This is Reza, legal counsel. A couple of things I just wanted to throw out there, bouncing off some of the other comments. First of all, I think Vicky's comment, the first comment, I second it with regard to some, the tone of some of the comments that were made. That said, if members of the public want to, critique the board or staff or anybody, they are free to do so legally. But of course, there's some bounds of professionalism and appropriateness, but nevertheless, you're more than welcome to critique the board as you see fit. The issue that's been brought up in public comment previously at the beginning of this meeting had to do, the majority of it, there may have been some other aspects to the public comments regarding intervention, but the majority of the public comments, from what I heard, had to do with this requirement that a participant in the program be required to work in a position where they will be passing narcotics for at least 6 months prior to, if you will, graduating from the program. That's what the folks in the public comments at the outset were kind of talking about and very critical of. And that's fine. The issue that I wanted to bring up from a legal perspective, on our agenda for today's meeting, there are a couple items, 9.3, 9.4, which relate to intervention. Neither of those is specifically on point on that particular issue of whether, a participant should be required to work in that capacity for that long to graduate. So my concern is that specific issue, we haven't noticed it on our agenda. We can discuss that issue, I think. Of course, our members of the public who brought it up in the first place can speak all they want about it. They're not limited. As board members, you all know under Bagley-Keene, though, that you are prohibited from talking about something that's not on the agenda, except to the extent that you need to talk about it to decide whether it ought to be on a future meeting agenda. So that's my slight concern. I think, when we open up public comment on those items, again, to those who already commented or still want to make comments, you're not restricted from continuing to talk about that. But for our board members, I would suggest taking whatever information you get there in, and if you'd like, putting that very specific issue on the agenda of a subsequent meeting. So we can dig in deep into that very specific issue, and so that members of the public know that that specific issue is on the agenda and can decide if they want to attend. I'm just slightly concerned that the way it's currently worded, that very specific issue might not have occurred to someone that it was going to be discussed. Do you have a question, Mary?
In many of the public comments, the response that we gave them was that we're going to talk about it at 9.3. So it sounds like now we're not going to talk about it at 9.3?
Yeah, to be honest, I think they can talk about it. Like I said, when it was said that they, that we'll be talking about it, I didn't really have a chance at that time to come back and, warn you in this way.
I think the one thing with the agenda item 9.3 was we can talk about the intervention program. That's what this is about, and that's what we can cover at 9.3. It's the specifics of whether or not the board can chime in to say you have to have 6 months with passing narcotics, or you don't have to have 6 months with passing narcotics. But with the 9.3, it's an overview of the intervention program. You can ask questions on how the intervention program works, why we're doing updates and such. This is a time for them to make comments about the intervention program, and they can make the comments that they want to be heard about the intervention program. But if we want to discuss specific aspects, which the ones that they're bringing up right now is narcotics specifically, that actually warrants a whole another agenda item. It's really in-depth process. There's many, many layers and many people involved in that. And an outside company, Maximus, it'd be great to have Maximus here as representation as well. DCA contracts with Maximus for all boards and bureaus. And so it might even be a benefit to have DCA here to really kind of further go into that. DCA is the one that has the uniform standards. We have our disciplinary guidelines. They work hand in hand together. And so with looking at making changes to that, because as Shannon referenced, uniform standards, those would have to go up through a chain up to and including DCA. And so for intervention overview, for intervention changes, for some of the stuff, absolutely part of the agenda item summary and on the agenda. But if we were to discuss specifically the narcotics, the passing of narcotics and the requirement of that as a board, that would require additional agenda item.
Well, those things issue came up in public comment at the last committee meetings as well, which is what
Yes.
the reason I thought we put it on the agenda here so that we could discuss it based on public comment at the last committee meetings.
Yeah, so it's a tapered in approach, because the first thing we have to do is explain what the intervention committee is and what they do and what kind of authority they have and why we're even looking at the intervention. And then we can get into details. And so we're still doing a collection as we're hearing all of these public comments. These same public commenters have been in the EIC meetings. They did go to ELC, which of course we directed them to come to board to do the public comment for items not on the agenda so that we can actually agendaize that. And so now that we're knowing that the information that is needing to be discussed is not just changes to intervention as a general, it is specific to the narcotic passing requirement that would change the agenda item, because we were under the impression that it was just the fact that there was changes happening within the intervention program. And so that was agendized so we can discuss a general intervention program. And then the next agenda item is to discuss potential regulations that we would need to enact if we wanted to do some specifics, because as Rez and I have said multiple times, that if we do something we do this the same for everybody, it has to be in regulation. If it is done on an individual assessment, then we can move forward with that because it's not a regulation that applies to everybody. And so that's another thing for discussion when we get into the next agenda item, because we do have several subsets of people that participate within intervention, not just somebody with a substance use disorder, but also with mental health issues.
I just one more follow-up. So will that mean it needs to wait to be agendized at the next full board meeting, or can it be something that can be addressed at the next committee meetings?
We can do an intervention, an enforcement investigations and intervention committee, the new name. We can hold that when we do the committee meetings. We can agendize it for that, and that committee can have a discussion, a robust discussion around it. But then obviously, I'm assuming our entire board would want to be involved in that. And so it may just be of benefit to have it all come to the board meeting so every board member can participate in it.
Okay, Neela Patel.
Thank you, President Trujillo. Shannon, I was wondering for uniform standard number 7, do you see that the EIC, the new name, monitors must have, applicants must have a monitor with the same scope of practice? Are you seeing issues with that, especially for advanced practice nurses who function independently and don't necessarily have someone there to monitor them with the same scope of practice?
Well, there is some extended language on that, which does give a flexibility if there is not an RN in the same scope. So there is some extended information. I just kind of took a clip of that. So if you want to see the extended information, it is within the uniform standards itself, which is quite a longer document. And I didn't want to keep you guys all day long going through that. But there is more in that document. We do also have that provision and flexibility within probation in the employment conditions that if it's an advanced practice, that we possibly have an advanced practice RN overseeing that work or if it's a nurse practitioner, possibly a physician, should that be the requirement. We also have in-house nurse who oversees that whole process on the probation side to ensure that we're meeting that as well. And then Maximus oversees it on the intervention side.
Allison Cormack, and then Trisha Nguyen.
Thank you, Chair Trujillo. I confess I feel like I still don't understand the problem that was described earlier. So we're not allowed to ask questions about that? I mean,
So the specific, and this all derives from Bagley-Keene and our obligation to give public notice of what we intend to talk about. Our agenda items regarding EIC under 9.0, 9.2 was the name change, 9.3 was generally regarding statistics, program updates, the Intervention Evaluation Committee's roles and responsibilities. 9.4 is about regulatory language. Those don't call out specifically that we would be talking about this very narrow issue of a 6-month requirement to work passing narcotics. So you are allowed to talk about what's on the agenda freely. As to that specific issue that I'm saying is not really called out specifically in the agenda, you can discuss it and ask questions only to the extent that is necessary for you to determine that that's appropriate for discussion at the next board meeting. Basically for you to decide whether you want to agendize it next time.
all right, let me try this question. You can stop if this is inappropriate. So this is for Ms. Johnson. Does the Intervention Evaluation Committee's roles and responsibilities include the specific kind of work assignments that must be completed before a nurse is released from the program, successfully completes the program?
The IEC's role is to review all aspects of the plan for that particular participant in the program and decide what is needed for that participant. And that is everything from treatment, testing, employment, group, community groups. It's really the full gamut. So they have the full authority to accept and terminate without board, without making a recommendation to the board. Everything as far as their care plan, that is all a recommendation to the board. So at every IEC, they review, they discuss, they vote, and then that vote goes over to Maximus to update the recovery plan, or AKA contract. It's referred to both ways. Then Maximus will update that recovery plan and post it to their portal to make available to the participant.
And then I'll further elaborate, Business Professions Code 2770.8. It says that their primary duties and responsibilities are A, to evaluate those registered nurses who request participation in the program according to the guidelines prescribed by the board and to make recommendations, to review and designate those treatment services to which registered nurses in an intervention program may be referred, to receive and review information concerning a registered nurse's participation in the program, to consider in the case of each registered nurse participating in a program, whether he or she may, with safety, continue or resume the practice of nursing, to call meetings as necessary to consider the request of registered nurses to participate in an intervention program, and to consider reports regarding registered nurses participating in a program, and to make recommendations to the program manager regarding the terms and conditions of the intervention agreement for each registered nurse participating in the program, including treatment, supervision, and monitoring requirements.
Okay, so the IEC makes recommendations to the board's program manager.
Yes.
Thank you.
Tricia Nguyen?
Thank you very much. And thanks, Shannon, for this presentation. The complaint that I have heard the most about Maximus since I started on the board is that in order to participate in this program, you have to quit your job. And I did not see that reflected in, the requirements. And I was hoping you might just explain kind of how that works.
So the ceasing of practice is in uniform standard over those first uniform standards. It basically states that every participant going into the program has to have a diagnostic evaluation completed. During that diagnostic evaluation, they must discontinue working until they get the results of that diagnostic evaluation. They also, at that same time, they must be tested twice per week during that time frame of getting that initial diagnostic evaluation. Once that diagnostic evaluation is received, then that participant, or excuse me, at the time, it'll be an applicant still, will need to go before the Intervention Evaluation Committee. And the Intervention Evaluation Committee will then have all the documentation available to them, which includes, complaints, any prescription history reports. They will have the evaluation with a possible recommendation from the clinician who provided the assessment. And then at that first initial meeting before the IEC, they will vote on whether or not to accept that applicant into the program. And then they will discuss what they believe or recommend the care plan should be, and they make that recommendation to the board. So there is a period of time to cease practice. It's at the beginning initial time, or if you read through uniform standards, there are standards that will dictate like the major violations. There's also a cease practice that could be applied during that time if one of the major violations are applied, or if multiple minor violations are applied. So there are cease practices during those times. There's also cease practices also in probation, just so you're aware, if there's positive test, or if through the mental health evaluation in probation, they are deemed not safe, then there are cease practices as well that can be put in place.
Thank you very much. I think that's very helpful. I understood that you had to not work, and that was an impediment to people going into this intervention program. So could you give us just a rule of thumb of what that initial period is, where you're getting your clinical assessment and waiting for your results approximately? I mean, is that a couple months or is that half a year?
I believe your initial intake with Maximus is within 10 days of actually contacting and requesting to go into the program. Then there's a period of time, just a few weeks, a couple weeks to have the diagnostic evaluation. And then once the diagnostic evaluation, it could be up to 3 months before you go see your IEC. For instance, as I stated, each IEC meets approximately every quarter, 4 times a year. If your IEC has just met, it could quite possibly be up to 3 months before you go to the IEC in order to formally be accepted into the program. However, the clinical case manager at Maximus will get them started on a pre-participant program, you know, getting them through the diagnostic evaluation with that cease practice, and then trying to get them set up with testing so they can get their random drug testing started, getting them set up with nurse support group. So there's some basics that they get them set up with in the preliminary stages prior to going before the IEC for formal acceptance.
Thank you. One last question. Do you see this, stop work requirement as being a major impediment to people participating in the intervention program?
Yeah, it can. I mean, honestly, it can be an impediment. I mean, if you think about it, you could quite possibly have a single parent, you know, that they're the sole breadwinner for that household. They can apply for disability to subsidize their income, but as we all know, that's probably not enough to, you know, allow for them to make it. So we want to move the process along as quickly as we can. We would like to get the nurses back working. We want to ensure that we have safe nurses out there in the field working. And so if we could get that process moving along, you know, we would benefit everybody. If we can make the program more enticing for our RNs to enter and not be so apprehensive, we're willing to look at all of that. In fact, you know, as I mentioned earlier, we've been attending the IEC meetings, we've been observing, we've been identifying, and that leads into one of our next agenda items. So we are looking, watching, listening, we're taking notes, we're trying to address everything to make sure that the board has a very robust and effective program that benefits everybody.
Thank you very much.
David Lawler.
I have 2 things. One is just to piggyback on everyone else's recommendation that we do agendize this. I specifically want to hear from Maximus. They need to be a part of this conversation. Any systems management, hearing complaints like that, the first thing I would do is some analysis of the whole system to see, is this universal? Is it a broken process? Or is this just individual anecdotes from 3 people? That being said, I assumed, because I'm not fluent in legalese, this is my second point, I need some guidance from Reza. I thought that's what 9.4 was going to do, have the discussion to create a more effective and efficient system. Can you tell me, as the illiterate person with legalese, the difference between what regulatory language is that we're going to discuss and fixing what could be a broken system that I thought we were going to discuss?
Sure. So first of all, as far as fixing a broken system, I don't know if you have in mind solely the kind of narrow issue that was brought up earlier this morning. Okay, so that's one element of what, you know, these at least 3 participants have been asked to do. That, you know, you might characterize that as a broken system, but I'd say that's simply one requirement. So, but 9.4, the agenda language is direct board staff to initiate drafting regulatory language for revisions and or additions to CCR Title 16, Article 4.1 Intervention Program Guidelines. It's very general. If we intended to get the board's approval or input on a specific topic within intervention, that topic would have been identified on the agenda, or you might have had actual draft regulatory language in your meeting materials about that topic. In the meeting materials for this, there are no proposed regulations or concepts or anything. From my understanding, I know that at the intervention evaluation committees over the last, X number of months, I believe they've had on their agendas a standing topic to just discuss amongst each of those committees and have those committee members kind of brainstorm ideas for improvement or changes and things. And I think my understanding was that this agenda item was likewise for you all to kind of brainstorm, and staff, meanwhile, have also been paying close attention to what's going on in the program, observing, reviewing, identifying maybe areas for improvement, and I would imagine have some idea of some concepts for proposed regulatory changes. Those concepts, again, are not in front of you today. I think the ask on 9.4 is just for the board to say, staff, go forth and put together some regulatory concepts for us to look at later. Again, you're not approving anything today under 9.4. And at that time, I think if you had, a topic that you wanted staff to work on in the off time, you could direct that. But it's nowhere in 9.3 or 9.4 does it speak specifically about the 6-month requirement of passing narcotics. That's my concern.
That's very
Of course,
helpful.
this is, I've advised you that we have that discussion openly, not that we sidestep it or avoid it. That's not what we're trying to do. The goal is to notify the public, and not just those few folks who happen to attend today, but anyone who might have an interest in that issue, and really get as wide of a swath of stakeholder input on that pretty significant issue.
Thank you.
Yeah, that would
That's
even
very
allow
helpful.
for employers to participate. Because when they look at a license, the intervention program is confidential. So I could be a member of the intervention program. You can pull up my license and it's going to say Loretta Melby and it's going to be clear. And you would have no idea. And so that is why it's important to get kind of all stakeholder feedback on that specific requirement.
Any other questions or comments from the board? All right, BRN moderator, can you please open us up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment."
This
Matthew
is Reza. I'm
A.
sorry, one thing I wanted to add. For our members of the public who might comment here, again, as I said before, you're free to comment on anything that you desire. Couple things though. First of all, the intervention program, the board maintains the identity of our participants as confidential. Secondly, under the Bagley-Keene Act, in order to comment at one of our meetings and participate, you're not obligated to identify yourself. So if you are in the intervention program and you wish to comment and you wish to identify yourself, that's your prerogative. However, you're not obligated to do so. And by identifying yourself, this is a public meeting, so you'll have possibly waived some confidentiality as to your participation in the program by identifying yourself. That's all I wanted to say.
And then, board president, for consideration, it looks like there may be only 5 people that have public comment right now. We have been keeping them to 2 minutes. I know that a member asked for 4 minutes this morning. Would you like to keep it at 2 minutes or move it to 4 minutes?
Keep it at 2 minutes.
Thank you.
Okay, thank you. Matthew A. would like to make a comment. 1 second, please.
Hello again. I hope everyone had a wonderful lunch. I disagree with Mr. Pejuhesh's notion that the agenda doesn't provide notice. As the agenda notes, we are talking about EC roles and obligations today. While narcotic access requirement was discussed here today and latched onto by some board members, the underlying issue is really the BRN not following the statutes, not that specific requirement, but that they're imposing the requirements at all. I think the board members that are asking some great questions here today, because these same questions are asked by participants, but are ignored or provided boilerplate answers to. I also appreciate Ms. Johnson going through the obligations of the ECs. It all sounds great on paper, but it's not being followed in practice. Going back to before the break, it was mentioned that Business and Professions Code 2770.8, that a committee created under this article operates under the direction of the intervention program manager, and that they're not supposed to be independent. I agree that's true, but 2770.2 explicitly states that no board member shall serve on any committee. Here we have board members as de facto committee members by appearing at every committee meeting, removing participants off their EC calendar if they did not meet the new requirements, and generally directing the committee members on what the recovery criteria and recommendation the board has for those participants. As Ms. Johnson explicitly noted, it's up to the committee to make decisions about treatment, not the BRN. Under 277.8 F, the committee shall have the following duties: to make recommendations to the program manager regarding the terms and conditions of the intervention program, including treatment, supervision, and monitoring. But that's not what's happening here. The opposite's happening, with the board making recommendations to the committee on what they should be doing. As you can tell by the number of people speaking about this issue here today and the many others that contacted me but were too afraid of retaliation, this is not just a few disgruntled participants. This is an endemic problem. Even the BRN's contractor Maximus themselves have urged participants to file complaints against the BRN to speak up about the issues. And Maximus had a number of case managers quit because of the BRN's recent changes, all while Maximus is too fearful to raise the issues themselves. What I believe has caused a lot of these issues are that these new changes were imposed across the board, whether you joined the program today or were one day away from completing after impeccable 4 years of compliance. Many of these issues could have been avoided if the BRN grandfathered participants who already joined the program to be able to complete under the former requirements. Last thing I want to mention is the effect it has on employers. I heard from nurses who are 3 or 4 years into programs who had their dream jobs in non-direct patient care roles, who now have to quit that job and find bedside work to comply with the new requirements. Not only does this obviously affect participants, but it affects employers as well. Employers are reluctant to hire and invest in diversion participants because of the constant changes and lack of clarity from the BRN. California is always experiencing a shortage of nurses. It's one reason the diversion program exists, to rehabilitate nurses and get them back to work. By punishing nurses who choose recovery over discipline, I can guarantee California.
Thank you for your comment. Anthony would like to
Before
make
we go on to Anthony real quick, I just want to provide some clarification for our stakeholders. There's a 9-member board that is you all that are up here. And that is what that statute is referencing, is that a board member may not serve on that committee. What he is misinterpreting is that Shannon Johnson et al. That are attending the IEC meetings are board staff. And they have every reason to attend meetings and appear and evaluate and such as part of the program.
Thank you. Anthony would like to make a comment. 1 second, please. Also be reminded to keep your comments at 2 minutes. Thank you.
Can you guys hear me?
Yes, sir. Go ahead.
Okay, I'm gonna try and make this real quick and try to make it real clear. There's been many participants who's been in this program for 3 to 4 years. They've met with their IEC members, and at each meeting, they've been told that they're on track to be able to I guess graduate this program successfully. You've met with them 4 times a year for the past 4 years. You've been impeccable. You've done everything that you're supposed to do, all the uniform requirements, but your date to leave or graduate is January 15th. But then you get a call on January 13th saying, no, we're not going to meet with you. You can't meet with your IEC meetings, your IEC, because all of a sudden, now you have to have a 6 month job where you're passing narcotics. That's the issue. Where you've been in this program for this many years, you've been told over and over and over again what your requirements were, and never was your requirement the 6 months to pass narcotics. You've done this for 4 years. You've paid $15,000. You've put your life on hold. You again have your dream job. And then all of a sudden, when it's time to graduate and move on with your life to either get married, be with your family, do whatever you're supposed to do, then all of a sudden it's taken away from you. That's the issue. It is not about passing the narcotics. If that was in the contract in the beginning, they would do that, but it was never stated. The contract stated everything you're supposed to do, and they did everything they're supposed to do. Many of these participants haven't met with their IEC in the past year. That's also an issue because there's an overturn. There's like a revolving door of it because a lot of the ICs are not there. Some of them are not even completed right now where they're looking to hire people for this. So the truth is the truth. And this is what's the issue. And it's not just 3 or 4 people. It's many people that this is going through that is hurting them. So we came today because we thought we were going to be heard today and to tell you guys this. And Maximus has no clarity. Maximus doesn't know. So they.
Thank you for your comment. Charlotte would like to make a comment. 1 second, please.
Yes, thank you. Again, on the same vein, I heard today that this is being described as a narrow issue and that there's maybe only a few disgruntled people. That is absolutely untrue. This is not a narrow issue. This affects everyone who's been in the program, like was previously stated, for years. And they were just grandfathered into this brand new proposed. And they're saying, oh, it's proposed and it's to be considered, but it's not to be considered. It's already been enacted because it's already affecting us as participants now. And this blanket has been put over everyone in the program without regard to their individual care plan at all. One of the other members brought up the financial hardship. I had 2 of my meetings that were completely delayed where I was unable to meet with my IEC committee. I was out of work for over 12 months. My state disability insurance that I had paid into had long since run out. Thank goodness I am married and I did have another person to help us, to help me financially. My husband was still working, but I was not bringing as you realize, California is not a state where it's very easy to live on one income. So the financial hardship of not only paying for, I know the board said, oh, we paid the fees. I pay the fee to Maximus every month, and also out of my pocket, all the drug fees are paid by me, not by the board. So it's not a narrow issue. It's a huge financial hardship for people that enter this program, especially when they're given the hope that they're going to be able to get through it and they're being compliant. They believe they're on track to finish, and now everything's been tossed out. And now I have to find another job where I am going to be passing narcotics for 6 months. So, and also with respect to the employers, they say, oh, it's completely confidential when you apply for a job. If you're in the diversion program, it doesn't show up on your license. That's true, but I still have to disclose it to my employer because I have to tell my employer that I have to have a worksite monitor who is going to monitor me. So that's not confidential. I had to let my employer know I wasn't going to lie to them in the interview and then say, oh, by the way, I'm in diversion and someone has to monitor my progress. So this is definitely not a narrow issue, and it has a huge financial impact on the participants and on the employers that are trying to employ these nurses. Thank you.
This is Reza, real quick, legal counsel. I'm the one that used the word narrow in describing this, so I just wanted to respond to that briefly. It was not intended in any way to, in describing this as narrow, that wasn't to say that this is a minor issue. That was not to say that this is insignificant in any way. It was narrow within the context of a somewhat technical legal requirement that governs our meetings. That is the Bagley-Keene Open Meeting Act. So it was within that context, not in the context of, the significance or the importance of it or anything like that. So I apologize if that was misunderstood. For those who have made comments on this and those that might continue to do so, you have been heard and you will continue. I'm sure this is a conversation that's going to continue. So even though there's some limit on what we can do today around this particular issue, please know that your time spent today was not in vain. You have been heard. It has, I think, opened the door to a robust discussion that remains to be had.
Thank you for your comment. Susan Parker would like to make a comment. 1 second, please.
Intervention program since 2021. It's been over 2.5 years. I also work in dialysis, which is a non-narcotic access position, and it is my dream job. I had my IEC meeting in December and was accepted to petition into transition, but was denied due to this new guideline of narcotic access. It's very confusing as this is not in my recovery agreement. I also do not have a future committee date, EC date on my recovery program agreement, and my case manager in Maximus said I could not get one until I completed the 6 months of narcotic access, as I have nothing to discuss, is what she said. So that's very frustrating. I'd still like to meet with the committee and let them know how well I'm doing in my program. This is a person-centered recovery plan, and we are told not to compare ourselves to others in diversion, but we are all struggling. This program's been very difficult. As you hear the standard requirements that are expected of us, I sympathize with Charlotte. Our urine tests are $5,000 a year. I've written to the my board of nursing representative twice in January, and did not get a response. Sorry. Is there a way to appeal, or why can't I do narcotic access while I'm in transition? It's holding me back at least 6 months, at least minimal. I haven't worked in narcotic access in 20 years, and it's hard to find a job. The requirements of the recovery agreement may be modified at any time by Maximus or a board designee in order to meet the needs of recovery. It seems that these things are added to keep us in longer, not to help us. I've been working, as I said, a year in my job of non-narcotic. For Maximus, I have to do a second clinical assessment evaluation that I'm already working. It's to say that I'm a safe nurse, but I've been working the past year, and now I have to pay for $225 that it's not free for the second evaluation. I'm just losing hope. I'm pleading to the BRN for their understanding and compassion in this challenging time. I volunteered into this program. I asked.
Thank you for your comment. David would like to make a comment. 1 second, please.
Hello, hi, my name is David. To dear members of the board and committee members and attendees, I am a participant actively engaged in the California Recovery Program with Maximus since October 28, 2020. After rigorously following the program's guidelines, multiple recovery agreements, I was approved for transition by the evaluation committee and Maximus on March 28, 2023. This is almost a year ago, with my next evaluation set for March 28, 2024 for potential graduation, a milestone achieved by many before me. The transition and transition recovery agreement was granted by the EC committee, with final formal recovery agreement outlining my set of requirements for the next 12 months. The support, the guidance from the STEAM program have been pivotal in my journey towards sustained recovery, bringing me closer to completion. However, recent issues with communication transparency, especially regarding changes to the program and its completion criteria, have compelled me to reach out. In November 2023, 3-year mark of my program, my case manager for Maximus presented my case requesting an evaluation committee hearing for final evaluation of my individual program, seeking dismissal, recognizing my transition phase and my 3 years of participation and fulfillment of all requirements, including IOP, personal counseling, neuropsych evaluations, AA meetings, having sponsored nursing support group meetings, ongoing drug testing, recommendation letters, life story essays, workbook completion, relapse prevention plan, worksite monitoring while being employed for their recommendations over 2.5 years in field of case management, which I've done for 15 years. And I have not had any narcotic access for the last 20, or worked in a narcotic access program in doing case management. So I was granted the meeting with evaluation committee, which was scheduled for December 15, 2023. Yet unexpectedly, I was informed just a day before that I had been removed from the agenda due to newly instituted requirements, the specific of which were not clearly communicated and never documented. Example of just one change agreement. This is from my agreement, from final agreement from transition. I must maintain continuous sobriety as determined by the EC or the board for a minimum of 2 years to apply to enter into the transition phase of the program, which is for 1 year or determined by the EC or the board. In order to successfully complete the program, I must comply with all terms of my recovery agreement. And there's a set of recovery.
Thank you for your comment. Caleb would like to make a comment. 1 second, please.
Hi, can you hear me?
Yes, go ahead.
Okay, thanks. I just want to briefly, I know there's a time constraint, but there's some points that I want to hit on as a participant in this program. I've been in this program for 3 years and 9 months. When I first entered this program, I was kept off work for almost 9 months. When I finally did get back to work, I have been consistently working since April of 2021. I have been a model participant in this program. A month before my final EIC, I was told by my Maximus case manager, there are some changes and the board is requiring now that everybody pass narcotics before they're able to get out. This is the first time that, we had ever heard of this. I had yearly, when I first got into the program, the EIC meetings probably were like twice a year, then that moved to once a year. And I have not seen my EIC committee since last year in February. Many of us don't even have a next EIC date. So to hear, the board, a lot of the things that they're saying, it just doesn't translate over, and it's just not what's happening in real life to the participants in the program. If the requirements were such that we had to pass narcotics to get out of the program, it would make sense that especially for some of us who were doing direct patient care, that we found a job in patient care, sooner rather than later. Some of us have been away from the bedside. So again, successfully working as a nurse case manager for, over 3 years. So now I'm being asked to do something that I'm not comfortable with, but to get out. And to further emphasize the point of the 6-month narcotic requirement, I want to be clear that we don't even have clarity around that. My Maximus case manager can't even tell me that the requirement is 6 months. She can't tell me how many hours I'm required to do it. I also have medical issues. I submitted documentation to that. The feedback I got was that the board said you need to find something that fits within your limitations. If you see my limitations, then you will see how hard or next to impossible that is. So my choices now to get out of this program are to quit my full-time job, to try to find a job that the board is requiring me to do that to fulfill requirements that I honestly don't even really fully comprehend, or stay, in my case management job and to support my family, and, and wait it out to figure out, what's going on behind the scenes, or try to get a job on the weekends to supplement.
Thank you for your comment. Participant XYZ would like to make a comment. 1 second, please.
I'm assuming you can.
Yes.
Thank you so much. I just want to let you all know I'm coming before you all feeling worried about speaking out, because over the last couple months I have spoken out and it has not had positive results for me. However, you've had attorneys, support group facilitators, and multiple representatives for participants and participants themselves speaking out. Many other nurses are remaining silent out of fear, and that is completely valid and understandable. It's not a matter, as you've heard, a handful of disgruntled participants. There are lots of us out here that do not understand what's required of us. Many letters that have been sent to other entities asking for help and advocacy. I don't believe it's the BRN's intention to hurt anyone, but I can assure you this radical silence we're experiencing, along with the imposition of continually added requirements that change at will, are causing harm. Ms. Johnson did an incredible job of discussing the program, of what the program entails. However, there's still zero clarity on exactly what is required to complete. In probation, every requirement is written out for them. For me personally, every requirement was written out for me until recently. In our recovery agreements, every requirement is written out for us. However, once we complete those requirements, new requirements are added. And for us, it feels like there's no change, no end to that. The board's mission is to protect the public through fair and consistent enforcement of statutes and regulations. What's happening here is neither fair nor consistent. Nurses, we need a safe and stable place to turn to receive help if we're struggling with mental health disorders or substance use disorders. Currently, this program is unfortunately chaotic, destructive, and punitive. Nurses will be more likely to avoid asking for help, which poses a much larger public safety risk. To Mr. Pujahesh, you had said earlier that a larger discussion needs to happen, and I fully agree. However, when does that happen? And what's happening to the nurses that are being extended continually and not being grandfathered in, and finding one reason after another to extend them in this program? Thank you so much for your time.
Thank you for your comment. Renisha Phillips would like to make a comment. 1 second, please. Renisha, on your phone, it's *6. Or try #6. *6 or #6? Are you not able to unmute? *6 or #6? Board President Trujillo, apparently she's not able to unmute. She's on a cell phone.
Can she type her comment?
Okay. Renisha, can you type your comment in?
Is there anybody else waiting to make comments?
No. I'm not seeing anything in the comment section.
Okay.
Okay, Board President Trujillo, there are no
Okay.
other public requests for
All right.
comments in the WebEx. And are there any public requests for comments there in Sacramento?
No requests for comment here in Sacramento.
Okay, would you like me to close this window?
Yes, please. Before we move on to the public commenters that have expressed their concerns regarding the Maximus program issue, I would just like to inform you that we would like to agendize this issue with Maximus properly in the May 2024 board meeting to give you opportunity to also voice your concerns then, rather than just public comment. Thank you. I believe this is the end of our 9.0 section. Okay, I'm sorry. There. Okay, sorry. 9.4, discussion and possible action regarding direct board staff to initiate drafting regulatory language for revisions and/or additions to California Codes of Regulation, CCR Title 16, Article 4.1, Intervention Program Guidelines.
Thank you very much, Madam Chair. Again, Shannon Johnson will be presenting on this item.
Everyone, so board staff is researching updates to the intervention program regulations to address any necessary clarification and/or gaps in the existing regulatory language. This will allow the delivery of an efficient and effective intervention program for RNs with substance use disorder and/or mental illness. So board staff is requesting authority to initiate the rulemaking process for proposed regulatory language for future consideration by the board.
Shannon, this is Reza. So just for clarification, board staff would, assuming the board votes on a motion like this in favor of it, board staff would come back later with some possible draft text
Correct.
or concepts or ideas for regulatory changes.
Yeah, I can elaborate more on the process there. So what typically happens is when we identify an area in regulation that needs to be added or updated, we will meet with subject matter experts. We will kind of get some background on the information, get recommendations. If it has to go to an advisory committee first, we bring it through an advisory committee who then looks at it, tears it apart, makes some recommendation, brings it forward. If we don't have a specific advisory committee for enforcement, we have our board committee. And so what we could do at that point is once we have some sample language, we can agendize it on an enforcement investigations intervention committee meeting, and then have some discussion. And then that committee can then make recommendations on whether or not they want to bring it forward to the board. When it does go to full board, the board can either accept, modify, make any recommendations, or say that's not the language they would like to pursue, and then it goes back out to staff again. If the board approves the regulatory language at that point, then we work with our board staff that's sitting back there, our Chief of Legislation, Marissa. She works with me and her team, and we get all of the documents gathered that has to happen with that. And so we do evidence-based, we write reports on this. We submit that up for DCA's regulatory attorney to review that. Once they review and clear that, then it goes to the DCA director. They review and clear. It can then go to agency for clearance, and then it comes back down to us, and we're able to move forward. And then it would go out to public comment. So we had talked about a couple different regulatory packages already, where they went to public comment. They came back after 45 days. We didn't have any public comment. But we also mentioned that if public comment was received, we would then review public comment, make a response to everything, and then go forth with that. So it's a very long process and a lot of points where people can give input, not just our board, but also our stakeholders.
Thank you.
Board Member Patricia Nguyen.
Thank you very much. I'd like to move that we authorize board staff to initiate drafting regulatory language for revisions and/or additions to CCR Title 16, Article 4.1 Intervention Program Guidelines.
Do we have a second?
I will second. This is Dolores Trujillo.
And as board's executive officer, I want to thank you guys for this. By listening to all of the public comment today, it's clear that they want some clear guidelines. And that is what regulation is all about. It does provide some very clear guidelines. It is law. It refers back to that. And I think that this is a path forward that would be helpful.
Can I get a quick question? What are the current I'm trying to look through the book to see what the current, Title 16, Article 4.1. Does anyone know what?
1446 through 1449.
Where do we find that in?
You can find it in your Nurse Practice Act under the CCR.
Maybe.
Yeah, I can help you.
Looking for it in the
and help us
code
just-
book.
I just like to look at.
Yeah.
I agree with the motion, but I would like to be able to see what we currently have in writing.
And then for those that don't have a Nurse Practice Act booklet in front of them, they can go to rn.ca.gov. And on the landing page is our homepage. You can scroll partially down.
It looks like
And
page
then,
122, Lori.
Yep. And you can go down to where it says General Practice Information, Advanced Practice Information, or Nursing Practice Act. You can click on the Nursing Practice Act. There are two separate sections. There's California Business Professions Code and California Code of Regulations. California's Business Profession Codes are the statutes that are enacted through legislation. The California Code of Regulations are the policies that we use that gets approved through the Office of Administrative Law to enact those statutory guidelines. Essentially. So then if you go down to California Code of Regulations, it is Article 4.1 and is the Intervention Program Guidelines. You can click on that. It will open it up to California Code of Regulation 1446, 47, 47.1, 47.2, 48, 48.1, and 1449. And then as Shannon did say, if you do have the book in front of you, that does start at page 122.
Thank you, Lori. Board Member Allison Cormack.
Thank you, Chair Trujillo. Just trying to connect the dots here. So it's a very broad motion, and there were no specifics before the motion was made. But what I'm hearing is that staff is requesting the ability to see if there's something that needs to be changed to address issues that have been raised today. Are there other issues that staff is also looking at? I mean, I understand we'll get a chance to look at it again. It's just that's very little information for us to make this decision. Not that, we won't have another chance. So it'd be helpful for me to know a little bit more about what are the things you're going to be looking at.
I can give you a little bit of background and then have Shannon elaborate more specifically if you need to. So as our executive team has kind of grown together and come in together since 2020 forward, we have been doing a step-by-step process with evaluating each one of our units and divisions and seeing how they're working. Shannon Johnson and the team that supports her, as well as her direct report, opened up intervention as one of the areas that we looked at. I worked and went through the nursing education consultant role of probation and did some revision through that. And so as they have been attending these IECs and they've been looking at how the program's been run, they have identified several areas where there are opportunities for improvement, specifically making things more clear for the participants, making ease of access to the participants. We've been receiving complaints about the financial responsibility, about their ability to work while in the program. And those are things that we would all like to address. Not just whether or not they have to work with narcotics for 6 months prior to graduation, because that can't be, of course, something that is put through for all, because there are people in there with mental illness And that would not even make sense for that to be a requirement for them because that's not an issue that they battle with. So there are many areas within intervention that we could possibly improve. Now, as a secondary on that, we entered as our board a study with National Councils of State Boards of Nursing on our intervention program. And there is going to be information that's given to us at the end of that study that is going to have recommendations on if we need to do anything to our intervention program to improve. Because there was a lot of studies that had been done that focused on graduation and completion of the program, but didn't look at recidivism, didn't look at relapse, and didn't look at anything 5 years down. So National Councils of State Boards of Nursing took that upon themselves and we joined that study. So we will also be incorporating that into any of that feedback into these processes as well for regulation update.
Okay, that's very helpful. So we should look at this as one of the many areas that the BRN will continuously be looking at improving. And also we will be partnering with the national organization and may do further revisions later.
Absolutely. And Shannon, do you have anything more to add to that?
Yeah, I just also want to comment too, several years ago, the board charged us with putting together a mental health ad hoc committee, which we did. And we brought in all the stakeholders to this meeting, and they produced a document based on a mental health diagnosis, not dual diagnoses, just mental health. That was never incorporated, even though it was presented to the board, it was never incorporated within our regulation. So we need to look at that in order to make a more robust program and really incorporate mental health more. I think we need to take a look at that result from that mental health ad hoc committee and see if portions of that need to be incorporated within our regulation language.
Thank you, Shannon. And that's been brought to light over and over and over since COVID, the need for mental health and the need for assistance with that for our nurses.
All right, any other questions or comments from board members? Okay, BRN moderator, can you please open us up for public oh, sorry. We're going to take a vote. Dolores Trujillo votes yes. Vice President Murray Fagan?
Yes.
Jovita Dominguez?
Jovita, yes.
There a question?
I'm not sure we've done public comment on this particular one yet.
It was 9.3.
You're correct. That was my mistake.
Okay.
Sorry. Thank you. So let's open up.
So let's open up for public comment before voting.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Matthew A. would like to make a comment. 1 second, please.
Hi, good afternoon again, and you guys are probably sick of hearing from me. I'll keep this one brief. I know this is a vote on whether to allow the BRN staff to draft some regulations. My only comment on it is the current regulations as they sit, it addresses criteria for admission to the program, causes for denial of admission, notification of termination, all this kind of general stuff around the program. What it doesn't say, and what I would hope a new draft would say, would be the exact criteria to complete the program, which is what obviously everyone here, many of the participants were talking about today. The other one I want to address is specifically section 1448, which is causes for termination from the program. Right now, they're so general that, and they're probably general on purpose to give some leeway, but they're so general now that I talked earlier about retaliation from the BRN. Any one of these can be picked by the BRN as a reason to terminate somebody from the program and justified because 1448 says, quote unquote, they are failing to substantially benefit from participation in the program. So I would like a little bit more clarity in any drafts on the exact criteria for terminating somebody from the program. Thank you so much.
Thank you for your comment. Chris Elf would like to make a comment. 1 second, please. Chris? I'll come back to Chris. Charlotte would like to make a comment. 1 second, please.
Definitely would like to echo what Matt said, and also as far as the guidelines that are going to be hopefully clear, incredibly clear to participants and anyone else as to what would constitute what the requirements are, not necessarily to be terminated. I didn't know if you meant by being terminated from the program, meaning being thrown out of the program, or if the correct compliance has been achieved, what the regulations are going to be that all participants have to be compliant with in order to graduate or complete the program, which obviously you've heard from lots of us that those have changed without any notice at all, for people that literally had the finish line right in their sights. So I'm just hoping that that's going to be part of the motion, and also that it would, I mean, we've said over and over again today, it's been mentioned that this is a very individualized program, and that the plan of care for the nurse should be individualized. In practice, it's not really that way, especially with this, again, narcotic requirement for participants who are not even in the program because of any narcotic. And I'm not talking about the mental health issues. I'm talking about participants that are in the program because of something that's non-narcotic or alcohol, something that has nothing to do with diverting narcotics at all. So I hope that will be made abundantly clear. Thank you.
Thank you for your comment. I'm going to go back to Chris Else. Chris, minimize any windows open on your computer, and there will be a little box that will pop up. Sometimes it hides behind other things that you have open.
If for some reason he is not able to unmute, we can have him type a comment. I know that previously today he's been able to speak.
Yes.
So we're hoping that he's able to get that worked out.
Yeah, the request is being sent, which means the window's opening up on his side, or it should be.
Okay. Just for planning for the board, as soon as this agenda item is complete, we will take a bio break, and then we'll come back and start the legislative updates.
Okay.
And the
One
board
more time,
president
Chris.
says 10 minutes.
Lori, we still have 9.5 as well. That should be quick.
Okay, perfect. Thank you.
Let's see, he can't seem to unmute, but I would like to offer each board member to attend one of my nurse support meetings. Since they seem a little confused on what I'm trying to convey to them, we hold our nurse support meetings every Wednesday at 5 p.m. via Zoom. That was Chris's comment.
Thank you for that, Chris.
Thank you. K.S. Svoboda, RN, would like to make a comment. 1 second, please.
I'm also a participant, reaching 3 years in the program in April. I think my greatest concern is that I have had a lot of my fellow, participants who are either in my nurse support group or who have graduated from the nurse support group but are still in Maximus, and I keep in contact with them as close friends, that they have heard, and been told verbally about this new requirement, and even rumors for a smaller group of people that, they need to go work with non-narcotics, but with patient care for the first 3 months, and then find another new job for 6 months with narcotics. However, at risk, I, out of fear, have not even brought it up because I just started a new job where I'm working with narcotics. I am not sure if, something's going to come back and, bite me in the butt as I'm, completing my orientation and going through and passing narcotics. But my greatest concern as well is everyone who has been told this by their compliance monitors or case managers, are they supposed to go with it without even having it in writing as well? Like, how believable can it be? And how much can we trust our contracts if, first of all, there's a part of our contract that says that you can change our contract at any time? So what's the point of having a contract? And also, if it's not in writing, how are we supposed to believe that this is truly going to follow through when we're jumping through all these hoops? It often takes us at least 6 months to find and start a job after going through all of the worksite monitor requirements and trying to explain, our employer's part in that, which a lot of the times they just turn us down because they don't understand, the complications of it. And I also am someone who has had surgery while I've been in recovery, so my jobs are very limited. I probably will never go back to inpatient or do 12s again, and yet I've had to literally, take jobs that I know are going to be temporary, just for this. These requirements that Maximus is placing on me. And when my employer keeps asking, when are you going to be done with this program? Because we already see you as a supervisor, that sort of thing. I have no honest answer for them. And honestly, I told them that I will probably find out the day of. And who knows when that meeting would be, when that will come, and that sort of thing. So the unknown, I acknowledge the idea to reassess some of the terminology in some of those, but as well, I feel like we're so far from anything being made clear to us as participants that so many more people are going to suffer before any solution is made. So I hope that I'm wrong. Thank you.
Thank you for your comment. Anthony would like to make a comment. 1 second, please.
Thank you all again. I'm going to make it real brief and keep it to the subject. When it comes down to new regulations or any changes that you guys make, I just ask that you have an effective start date and possibly a grandfather clause to help people that's already been in the program if there is any drastic changes. That's all. Thank you.
Thank you for your comment. Chris, I found you in another spot. One more time. Chris Else. You're on here twice. Once on a phone, on a cell phone, and one on a computer. So I found the cell phone.
Hello?
There he is. Thank you. Sorry about
I,
that, sir.
I apologize. One of them must have not disconnected me from my computer, but I think you conveyed exactly what I needed to say. I just wanted to invite any board member who is just a little, I may have not expressed myself well enough. I would love them to attend one of the nurse support meetings. Maybe the nurses can explain in a calm way what's really going on with them. These all seem like a whole bunch of things going on, but when you all put them together, you can see how overwhelming some of these regulations can be for some of the nurses. And I just, like I said before, just a lighter hand. That was it. Thank you for your time.
Thank you for your comment. Board President Trujillo, there are no other public requests for comments on the WebEx. I see there are no public requests for comments there in your location in Sacramento. Would you like me to close this window?
Yes. Yes, thank you.
And then real quick, Reza Pedres, are board members able to view a Zoom of a nurse support group meeting of like they were invited. I want to make sure that legally we give them some direction right now so that there's nothing that goes wrong if
Yeah,
they're not able to.
It's a good question. When that was suggested by, I think it was Mr. Else, a number of issues crossed my mind. I don't have an answer on the spot here to those issues. You know, confidentiality comes up of program participants. Secondly, the fact that intervention is not disciplinary, but conceivably, theoretically, folks who are in intervention could line themselves up in discipline, and that's for, again, technical legal reasons, an issue. So it is on a practical level understandable as a recommendation from Mr. Elsey, but something that I would have to take a look at more closely.
So what I would ask is that we have no board members participate in a Zoom at this point until we can get official legal interpretation.
Thanks, Lori. So I think what is probably needed right now is we need to restate the motion.
Please, I have board staff reach out to restate the motion and who seconded it.
Go ahead, Patricia.
Thank you. I would move that we authorize board staff to initiate drafting regulatory language for revisions and/or additions to CCR Title 16, Article 4.1, Intervention Program Guidelines.
And I second the motion. This is Dolores Trujillo. We have on the public comment. We can now take a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen.
Nguyen, yes.
Board Member David Lawler.
David Lawler, yes.
Board Member Vicky Granowitz.
Granowitz, yes.
Board Member Allison Cormack.
Cormack, yes.
And Board Member Neela Patel.
Patel, yes.
Thank you. Moving on to 9.5. This is discussion and possible action, appointments of Intervention Evaluation Committee, IEC members.
I don't see their resumes or any information about these members in our materials, board materials.
They are not in your board materials. They were emailed out to you guys this morning.
Oh, okay.
For
So-
clarification, that's something that's given only to our board members because it contains personal information. So it's not put in the public meeting materials.
May I make a suggestion that we take a 10-minute break? I have not looked at my email. During that 10-minute bio break, I will do a quick scan and maybe then we could proceed.
We still have ledge to do, so we can defer this section and we can come back to this after ledge, and that might put us into tomorrow morning.
Okay.
I don't think that we will finish ledge today before 5 o'clock, and I do have board staff that have to exit at 5. So we will continue our board meeting tomorrow morning, and we could move 9.5 to one of the first items. And that will give our board members adequate time to review so they don't feel rushed.
Thank you, Lori. So right now, the board will break for a bio break for about 10 minutes. So we will return at 4:20. Thank you. Board meeting. Starting with item 10.0. This is the report on legislation. I chair this committee. Marissa?
Good afternoon. Thank you. So before I jump into the bills, I just wanted to highlight, this is also in your agenda item summary, but Bill number 1, AB 1944, Bill number 8, AB 2526, Bill number 10, AB 2578, Bill number 12, AB 2679, and Bill number 13, AB 2682 do not have analyses. Again, it's on the AIS, so you can refer to that as well. The reason was either the bill was still in spot bill format, so there just wasn't anything to analyze. One of the bills, we found after it was listed, we confirmed that it would not impact nurses, so it didn't need to come before you all. And then one, I personally transposed the numbers, so I very much apologize for that. But per Bagley-Keene, we can't discuss something that is not accurately reflected on the agenda. The good news is it's still in a very early version, so we will have a chance to discuss it at our next meeting. Okay, so the first bill we're going to discuss is Assembly Bill 2015 by Assemblymember Schiavo. And this was discussed a little bit earlier today. It was a proposal put forth by the board in an attempt to improve upon and streamline our current faculty approval process. The way our current faculty approval process is set up, the approval is tied to the nursing program, not the individual applicant. So currently nursing programs will go through their recruitment, application screening, interviews, and then at the very end of the hiring process, prior to submitting the top candidate, or excuse me, prior to extending their final offer to the top candidate, submit them to the board for approval. So if in the chance that they are not approved, that entire process could have to start all over again. But even if they are approved, that approval under the current process is tied to just that one nursing program. So if the approved faculty member wants to teach the same subject at the same level at a different program, that other program would have to put the applicant through the board approval process all over again, creating some redundancy there. So this bill would essentially kind of flip the process by making the faculty approval applicant-based rather than school-based. And this aligns with how other teacher credentialing bodies in California operate. So under this bill, an individual would apply directly to the board to receive approval to teach at the level and in the content area that aligns with their experience and qualifications. Their approval would then be connected to their nursing license and viewable on the DCA license lookup page that I think Lori pulled up earlier. So it'll be very easy to reference for nursing programs who are doing the hiring, as well as just the general public. This change will allow schools to verify whether an individual is approved to teach, at what level, and in what content area. At the same time, they're verifying whether the applicant has an active nursing license. So this, we're hoping, will help ensure that nursing programs' really finite resources are spent interviewing applicants who have already been approved by the board. And it will also mean that an applicant does not have to re-seek board approval at every job they apply for if it's in the same position and content area. So the bill would also add some additional flexibility to the current remediation process by allowing the board to grant a temporary approval while an applicant becomes competent in a new teaching area. So under current law, if an existing faculty member does not have competency in a content area that is needed for a new position or assignment, the nursing program may use the board's faculty remediation process to assist the faculty member in becoming approved in that new nursing content area. This bill would add some additional flexibility by authorizing the board to provide a one-year temporary faculty approval in the new nursing content area while the applicant is completing their board-approved individualized remediation plan. There are some kind of exceptions there, is that the temporary approval would be only applied to instruction in theory courses and would require the applicant to remain under mentorship and supervision of a content expert for that nursing content area. And then lastly, there's some provisions around reporting. So under current law, nursing programs are required to report to the board any changes in their faculty, such as hiring, firing, quitting, changes in content area, etc. So this bill would try and remove some of that unnecessary reporting by actually prohibiting us from requiring schools to report any of the following: a change in the faculty member's teaching area, an offer of employment for a faculty member position, or a termination of employment of a faculty member. So that would mean that pretty much the main things that they would have to report to us is who their program director is and who their assistant program director is, because that is who we do the majority of the business with around approvals and whatnot. So that is a quick synopsis of the bill. Are there any questions?
Board Member Allison Cormack.
Thank you, Chair Trujillo. This all makes sense. Sounds reasonable. Can you give us an example of how this has been problematic in the past? The sort of the problem we're trying to solve?
Yes, definitely. So we hear multiple complaints from our academic partners that the board is a barrier. And so what occurs in our current process is, and I'm talking in a perfect world because this is not real life, is they receive 5 applications for a position. Real life is they have a failed search, 0 applications, or they have 1. But say they receive 5 applications for a search for a faculty member, they go through, they choose the person, they interview the person, everything is great. They go to the hiring committee, everything is fine. And the program director then submits a faculty approval form to the NEC for review. The NEC then reviews it and says, you're not qualified. And they cannot hire them for that position. It's backwards. And so we said, why are we doing this backwards? And why don't we put this on the front end? And so the analogy that I used with talking with non-nursing academia was you have a driver's license and you want to be a truck driver. So you go and you obtain your CDL and then you apply for a truck driving license. And that's exactly what this process would be. You would be an RN. You want to be a faculty member. You'll get approved as an RN faculty member, and then you apply. So that way, anybody that applies for that position is qualified. The program director can verify that as they're going through the hiring process, and we do not need to be involved. There is no way that we would then block or be a barrier at that point because they're already there. Now, we have heard some discussions that says, well, we go out and recruit people, and that can do the same situation as if you're running into them in a clinical setting or you work with them and you say, hey, you'd be a great instructor, I want to hire you. At the same time you're having that conversation, tell them to go to the BRN website, apply, get approved, and then that way they're done. So you're not getting to the end of the hiring decision to say, okay, now you're not qualified.
I guess it's a little concerning to hear that someone would get to the end of the process and then realize the person they were hiring didn't have the qualifications required. But if we can be helpful, then I guess we should be helpful.
Yeah, one of the big qualification issues is that for specific nursing content area, med-surg, OB, peds, psych, mental health, and geri, you have to have a 5-year recency, which means within the last 5 years, you've had to work at least 1 year in that area so that you're recent. And many times, and with the current faculty crisis, people will go and find an educator or a manager of a unit who has not done patient care in 5 or 10 or 20 years, and they think that they should be able to come in and teach. Very similar to the last discussion where an RN license is an RN license is an RN license. You have carte blanche to work in any area that you're hired. That too is the process here for faculty. Once we approve you for faculty, you're able to teach both theory and clinical. So you will have an opportunity where you do go to the bedside, where you are taking care of patients. And so part of that recency requirement is there. There is a disagreement with certain organizations about that recency requirement, but there is a lot of research done at the national level, especially with NCSBN, that recommends a 5-year recency.
Okay, that's helpful. Thank you.
Board Member Neela Patel.
Thank you. So I have a question for this bill. If it were to pass, is there a fee associated with it to apply for this particular license?
There's no fee.
No, and there's currently no fee for this process. So what we did with this bill is we took our regulatory language and moved it to statute. So we're not adding any new criteria or making it more difficult. We literally went from a 10-step process that was on the back end, moved it to a 5-step process on the front end, and then added additional leniency with that 1 year.
Board Member Mary Fagan.
The document here talks about the leveling as well as content area. Does that mean whether they could teach an associate degree versus baccalaureate, or what's the leveling?
No, so the leveling is right now, again, this is what we currently do. We have a clinical teaching assistant, which means you have no degree requirement. You just have to be licensed as an RN with 1 year experience. That person can help out in a clinical, maybe do some treatments with a clinical instructor present. They can work in the lab and do some simulation or some skills. They can guest lecture a certain specific content within a theory, but they are not a course. They do not have the ability to give grades or anything to that effect. They don't own that course. They're just kind of participating in the delivery of. Once you have a bachelor's degree or higher, you qualify to be an assistant instructor. If you are an assistant instructor with a bachelor's degree, you will maintain that. in your content area, of course, if you maintain your recency. If you are master's prepared, when you originally come out from your degree, you might not have any teaching and experience, you would be approved as an assistant instructor. And you would work for 1 year in assistant instructor role. That allows you to own your clinical group. You can take them out to the clinical sites. You can do some theory under a theory and instructor level faculty and content expert. And then you can move on to a full instructor status. So if you compare it to like what we were talking with the school nursing through the Commission on Teaching Credentialing, there's a preliminary credential and then a full credential. The assistant instructor is very similar to a preliminary credential, and your full credential is very similar to an instructor level. So those are your levels. They're clinical teaching assistant, assistant instructor, and instructor.
And then the applicant would have to apply for each of those that they would want.
Correct. If they meet criteria, if they never advance their degree past a diploma or a certificate or an associate degree, they will never advance past a clinical teaching assistant. If they never advance past a bachelor's degree, they'll never advance past an assistant instructor. But master's degree and higher will allow them to traverse through all the areas.
Thank you, Lori. Any other questions or comments from the board? I would like to make a motion to support, for the board to support this bill.
Jovita seconds.
Thank you, Jovita. BRN moderator, can you please open it up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. I can see there's no public requests for comments in the Sacramento location. Would you like me to close this window?
Yes, thank you. Okay, we're going to take this to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Jovita Dominguez.
Dominguez, yes.
Board Member Tricia Nguyen.
Win, yes.
Board Member David Lawler.
Lawler, yes.
Board Member Allison Cormack.
Cormack, yes.
Board Member Vicky Granowitz.
Granowitz, yes.
And Board Member Neelu Patel.
Neelu Patel, yes.
Thank you.
So the next bill is Assembly Bill 2104 by Assemblymember Soria. And so I'll start with a little bit of background just because I think it helps give context for the bill. Kind of broadly historically, according to the Master Plan for Higher Education and state law, the education systems have had their own jurisdictions. California community colleges typically have bore the main responsibility for lower division undergraduate instruction, where the California state universities offer undergraduate and graduate instruction through master's degree. And then the University of California has sole authority to offer doctoral degrees, although there is an option to offer a joint doctoral degree with the CSU system in selected fields. So in 2014, Senate Bill 850 authorized the community colleges to establish a statewide baccalaureate degree pilot program at 15 colleges. The programs under this pilot had to meet kind of a handful of different criteria, such as addressing unmet workforce needs and not duplicating degrees that were offered by the CSU or UC systems. So consequently, nursing was not included in that first one because it was considered duplicative as it was offered by other institutions. So that went on for a few years, and then in 2021, AB 927 authorized the community colleges to expand and extend the operation of that pilot program indefinitely. The bill also authorized the community colleges to establish up to 30 baccalaureate degree programs in 2 application cycles per academic year. And that has been going on since that bill passed. So this bill would require the chancellor of the community colleges to develop a baccalaureate degree in nursing pilot program that authorizes select community college districts to offer a Bachelor of Science in Nursing degree. The bill would limit the pilot program to 15 community college districts statewide and would require the chancellor to identify eligible community college districts based on at least 2 of the following criteria. Community college districts demonstrate equitable access to the pilot program with a particular focus on regions showing a need for healthcare professionals. Priority is given to community college districts that are located in broadly recognized underserved nursing areas. And priority is given to community college districts where the service area of the community college district includes communities with persistent poverty. So the bill would limit the total number of participants in a pilot program at a community college district to 25% of the community college district's associate degree in nursing class size. However, there is an exception for community college districts located in persistent poverty communities. They are allowed to increase the participants up to 75% of the community college district's associate degree in nursing class size. And so lastly, the bill would require the Legislative Analyst's Office to conduct an evaluation of the pilot program to determine if it's effective and whether there's a need to continue or expand the program. And the bill would also sunset this pilot program as of January 1, 2031. Happy to answer any questions.
Any questions?
Yeah.
Board Member Patel here. Do you know if there's an opportunity for those that already have an ADN to go back to these community colleges to obtain their BSN through this route?
You're good. Yeah.
I know that the community colleges are looking at that. They're looking at that they want to do an RN to BSN. Just doing a straight read of the language, it doesn't state that they can't do an RN to BSN because they would be granting a Bachelor's of Science in Nursing. So they potentially, unless of course the language changes, offer a RN to BSN in addition to their ADN.
And I think the language will definitely continue to flesh out after this being the first take. I think there's a pocket of areas where there's kind of questions such as that. They're a really good one.
And Board Member Fagan, one of the biggest barriers that we've heard again and again for community colleges being successful is being able to recruit and retain adequate faculty. So I'm just wondering if the bill addresses either faculty pay or anything that would be able to support the community colleges to get the faculty they need for this BSN programs to be successful.
It does not at this time. And I think that is something we have heard, and we've kind of discussed this with a variety of stakeholders, that, you know, just as to your point, some of the same issues that impact one public university system are impacting the other public university system. And so at this time, there isn't any language in there that would kind of mediate that in a way that's different than it currently is.
Is that something we could potentially request for support if amended or something like that potentially?
The board should not be involved in any kind of wage discussion. There's always, when we're a licensing entity, we should not have any kind of conversation around pay.
Maybe if it's not wages, but just adequate support, something like that. I don't know.
I believe there is a lot of attention on this matter through the various unions, and they're working through various aspects within meetings with workforce and with governor and such to get some provisions. We have shared that Washington State had a union-led bill that did address faculty wages, and that is now removed the sunset date for that because it was so effective. So we have shared that out. We've provided that information, and we hope that an entity that could put something in there about wages and support would be able to carry that through. But even in our last sunset, there was a legal group that came out that really looked at the position of an RN in the EO role, an RN majority in the board role, and accused us of potentially limiting access to license to artificially inflate wages. So we do need to stay out of that kind of wage conversation as a board.
Board Member Vicki Granowitz.
Thank you. We're seeing some community colleges having trouble getting clinical placements. And so with this, there's not only going to be issues with getting clinical placements, there will also potentially problems with impaction. So how is all of that being taken into consideration?
So there's a couple different pathways that could happen here. One is if you're doing an RN to BSN, there's no additional clinical requirement. If they choose to offer a public health nurse certificate as part of that RN to BSN, there is 90 hours total that are required to be within community health. And those are not in the traditional med-surg OB-Peds like mental health and Jerry that you see within your pre-licensure programs. If they do not choose to offer a pre-licensure BSN and do the RN to BSN, there would be no clinical impact essentially at that point. If they do a pre-licensure BSN, if they say they are approved to enroll 100 students a year, and they decide that 80 of those students stay in the ADN program, and we're going to open up for 20 students to be in the BSN program, because the clinical requirements are the same regardless of the degree option, it would be a zero impact, it'd be mute. So they would be utilizing the same clinical sites for the same amount of time, doing the same programs. Where there would be clinical impact is if a program did their associate degree at 100 students a year and then came in front of our board to approve the new BSN curriculum and then add additional enrollments. And so that is where we would then consider an enrollment increase, where would be whatever they asked for, and then we would evaluate the impact at that point. But there would be an impact. And with meeting with some various stakeholders, there was thought that maybe students would be pulled from maybe a CSU system to go to community college. If that were to happen, you would see a shift in resources, which would be problematic as well.
Okay, Board Member David Lawler and then Board Member Allison Cormack.
Thank you. Just really quick, if we have to take positions on each of these bills through your report, we can take no position or a watch position.
Correct.
At this moment, my question is, if we took a watch position, which in other places means we'll work with the maker on the bill, does BRN have that same kind of authority to work with the maker of the bill to address some of these questions?
We have that whether you guys take a watch position or not.
All right, good.
We're always working with the writers of bills that impact the board, just on implementation.
Board Member Allison Cormack.
Thank you so much. So 2 questions. One is, so the analysis says that the data they would be using includes underserved nursing areas. Would they be getting that information somehow from BRN data to figure out what an underserved nursing area is?
I believe, does HCI have that data?
HCI.
Yeah,
HCI,
the Department
okay.
of Healthcare.
All right, and the other ones are straightforward. And then, so I see SB 895 seems, is it identical? Or should we be considering them together?
Close. I mean, they essentially, I would say they're 90%
Parallel? Yeah.
the same. I think the criteria you'll notice is a little bit different, but I think in the same spirit. And then I don't believe the limiting to the 25% with the extension to the 75% is a little bit different. In SB 895, I believe it says 25% or 35 students, whichever is higher. So they are
Okay.
very, very similar. You're correct.
Okay. All right, thank you.
And we do have some community colleges that do have a much larger enrollment number than others. And so that limiting factor could be key.
Board Member Tricia Nguyen.
Thank you very much. So do you think it's too soon for us to evaluate these, or should we support and just be part of the conversation?
You know, that's completely up to you guys.
Okay.
Any bill that's introduced is not going to be the bill that gets signed
Yeah.
into law at the end. So if what's in front of you is something that fundamentally you can get behind, then you can do a support.
Okay.
If there's something in there that says, oh no, you maybe do a support with amend or you do oppose. But we have at least two more board meetings, I think, before the end of the legislative session. So if these change dramatically, we can always change our position as well.
Thank you.
Any other comments or questions from board members? Would you like to take a position of watch or support?
I'll move a position of watch
Okay,
on AB 2104.
I'll second that.
thanks, Mary. BRN moderator, can you please open us up for public
Sorry,
comment?
may I ask a quick procedural
Oh,
question? Do we have to take a position at all?
No.
So we could move to take no position on this at this time, and you would
Right.
still
We
do
could.
the same amount of work that you were doing?
Absolutely.
And does watch signify a different, so if I'm in the legislature, if we take, what do they interpret from watch vis-a-vis not taking a position?
I think they'd probably
It'll probably be the same,
be
wouldn't it?
about similar.
Yeah.
Yeah, I think knowing the discussion, watch kind of signifies like, okay, this is something we've expressed our interest in. We're not quite ready to go, either way. No position, depending on how the conversation goes, could mean we just don't think it's relevant, So I think it just depends on the tone
Okay.
and the desire.
Okay.
But having heard the conversation, I think the tone is definitely we're interested whichever way we go.
Thank you for that
Then
clarification.
some stakeholders might see no position as we haven't taken a position where it hasn't been heard. And so sometimes in conversation, they'll be like, does the board have a position? And you say, no, the board doesn't have a position. They don't give you a chance to say, the board
Yeah.
took no position and
Okay.
clarify.
All right. So watch, it's not the same as like when you're watching your toddler and I'm like, I'm watching you. It's more like, okay, I heard something happened. I'm going to keep an ear out.
No, that's Marissa's job and she is, I'm watching every single bill out.
All right. Thank you.
And I also am wondering about, because this other bill is so similar, do we watch both of them? Is there typically a process if there's two bills that look very similar that the parties get together and come back with one?
They typically work themselves out at some point in the process. At this point, there's really no way to know which one will kind of reign. But we've seen in past years like bills that just have similar content areas. This year, for some reason, we have a few sets that are just very similar in language. And obviously, they'll kind of as the process moves on, peter themselves out essentially, and one will
Maybe
kind
that's a
of.
reason, maybe just to watch both of them and see what comes out, right?
Okay, we have a first and a second on the floor. BRN moderator, can you please open this up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, I would like to make a comment. Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment.
While they're waiting for public comment, I just want to call attention to the time. It is 4:50. I do have board staff that do need to end at 5 o'clock today. And so we'll probably have one more bill discussion before we recess today and reopen tomorrow at 9 a.m.
Board President Trujillo, there are no public requests for comments in the WebEx. There are no public requests for comments there in Sacramento. Would you like me to close this window?
Call the other community college bill forward. Yeah.
Close the window. Oh, Mark asked to close the window. Oh, sorry.
So yes. Yes, you can close public comment.
Yes.
Thank you.
And then Marissa,
Yes.
it has been asked to pull the other similar bill forward.
Yeah, of
and
course.
discuss that one now at this point.
While you're doing that, Marissa, we'll go ahead and take a vote. We are taking a position of watch at this time. Dolores Trujillo votes yes. Vice President Mary Fagan,
Mary Fagan, yes.
Board Member Jovita Dominguez,
Dominguez, yes.
Board Member Allison Cormack,
Cormac, yes.
Board Member Vicky Granowitz,
Granowitz, yes.
Board Member Patricia Nguyen,
Win, yes.
Board Member Neelu Patel,
Patel, yes.
and Board Member David Lawler.
Lawler, yes.
Okay, thank you.
Okay. So this next bill is Senate Bill 895 by Senator Roth. And similarly, the bill would require the Chancellor of the California Community Colleges to develop a baccalaureate degree in nursing pilot program that authorizes select community college districts to offer a Bachelor of Science in Nursing degree. The bill would limit the pilot program to 15 community college districts statewide and require the Chancellor's office to identify eligible community college districts that apply based on the following criteria. There is equitable access between the northern, central, and southern parts of the state to the pilot program. Priority is given to community college districts in underserved nursing areas. The community college district has a nationally accredited nursing program. So for this one, the bill would limit the total number of participants in a pilot program at a community college district to 25% of the community college district's associate degree in nursing class size, or 35 students, whichever is greater. And again, the bill would require the Legislative Analyst's Office to conduct an evaluation of the pilot program to determine the effectiveness and whether there's a need to continue or expand. And the bill would establish the same program sunset date of January 1, 2031.
Thank you, Marissa.
I
Board
would
Member
move-
Patricia Wynn.
Thank you very much. I'd move that we adopt a position of watch on this bill at this time.
Thank you. Any seconds?
I'll second David Lawler.
Thank you, David. Any questions or comments from the board? Allison Cormack?
Thank you, Chair Trujillo. I noticed the support is different for this, right?
Yes.
So talk to us about that a little bit.
Yes, thank you for asking that question. So with this early in the session, it's a little tricky because one of my kind of rules when I'm putting information is I want to make sure anything around a position or sponsor is verified. And so because it's so early, there's no committee analysis. That's typically the first place. So what I did do is reach out to all the authors for fact sheets. And if I received one back and it had, it is sponsored by this entity, it has support by this entity, I documented it. But if I didn't receive a fact sheet or if it didn't say that, I didn't want to assume. And so I didn't put anything down there because there wasn't anything in print.
Okay, so it's possible that these same organizations might also support the Assembly bill. We just don't know.
Correct.
Okay, thank you.
Any other questions or comments from board members?
I just have the requirement that the community college be accredited by a national accrediting. Most of the community colleges are not accredited, right? Is that going to create a barrier, or are there going to be resources to help them get that accreditation? Because that requires resources, right?
I think it would narrow the selection. It absolutely do that. So if they just went on accreditation as being a golden ticket, it would not be open to all community colleges. All community colleges have board approval. Some have an optional national accreditation.
But a real small number, right? Do we have
Right,
that
it's
data?
growing. It's definitely growing, but it's a slow process and it is a lengthy process to get through that.
This bill could maybe help support them to pursue it, right?
It could, absolutely. But again, that comes down to funding. And community colleges get their funding from the state. And so that would be a very difficult thing for them to have to pursue in the current budget.
Any other questions? All right, BRN moderator, can you please open it up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. There are no public requests for comments in the Sacramento location. Would you like me to close this window?
Yes, thank you. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Vicky Granowitz.
Granowitz, yes.
Board Member Jovita Dominguez,
Dominguez, yes.
Board Member Allison Cormack,
Cormac, yes.
Board Member Patricia Nguyen, Board Member Neelu Patel,
Patel, yes.
and Board Member David Lawler.
Lawler, yes.
Thank you. We will now recess our board meeting for today, and we will be back tomorrow morning at 9 a.m. Thank you.